I thank AIOS for giving us this opportunity to present this IC. Today's IC, I've titled it as Unleashing the Leash. So we are discussing about the restrictive strabismus. There's one change in the speakers. Dr. Ramesh had to go because his flight was cancelled and he had some session in Kathmandu. So Dr. Vivek Varkad would be talking on the topic Dr. Ramesh was supposed to talk. Can you please put the introduction slide of Dr. Vivek Varkad in the introduction? The last slide. No, the last slide of the introduction. No, the one prior. One before that. Yes. Uh, Dr. Vivek has completed. I invite Dr. Vivek for his talk on thyroid ophthalmopathy, how to tackle the diplopia surgically. Dr. Vivek has completed his medical education from Nasik, and then he has done his residency from Darbhanga Medical College. He has done 2 fellowships from LVPI, one in comprehensive and one in pediatric ophthalmology and three in fact. He's joined LVPI Bhubaneswar campus as faculty since 2013. Vivek has presented papers and published papers and videos and delivered invited talks at various national and international ophthalmology forums. His area of interest include pediatric cataract, strabismus, neuro-ophthalmology, and he has served as a task force officer for RBSK program of NHM Odisha for congenital cataract, and he's recently completed an international fellowship in complex strabismus at Boston Children's Hospital, Harvard Medical School. So his views will help us to understand thyroid ophthalmopathy better. Dr. Vivek, please.
Yeah, so thank you so much, Dr. Shubhangi, for nice introduction, and thanks for giving me this opportunity to present in this IC. So good morning to everyone. So basically today I'm going to talk about how to tackle the strabismus in thyroid eye disease. So I think this is the Rundle curves which every strabismologist who operate or deal with the strabismus in thyroid eye disease, they are aware about. So we need to be very much clear about the activity of the thyroid eye disease. So as we know that there are different phases, right? So the dynamic phase where the patients have the very active and severe thyroid eye disease, then it becomes a plateau, then the activity goes down slowly over a period of time, and disease become the psychiatrical. So once you are aware about that, you can take the calls for taking strabismus surgery in this group of patient. So abnormalities of extraocular muscles on imaging is seen in almost 80 to 90% of the patients with TED. Clinically, they are apparent in 30% of the patient. So ocular deviation is the most common presentation, followed by diplopia, and the most common strabismus pattern that we see in our practice is hypo and esotropia, for the obvious reason, because the extraocular muscle involved in a descending order could be IR, MR, SR, and then the LR, which is least common. 3 to 8% of the patients, the myasthenia gravis is associated with a kind of a thyroid eye disease, and you need to be very cautious because we know that the OMG is a masquerading. So you need to suspect and subject appropriate test so that you can rule out that there is an underlying ocular myasthenia associated with TD. So let's start with this particular patient, 53-year-old lady who is a housemaker, presented with double vision, horizontal and vertical diplopia since 6 months, and there was associated drooping of the left upper eyelid. So if you see that, this is her past medical history where the neostigmine test was positive and ACH receptor antibodies were negative. So she was put on the medications, and there was a past medical history of various disorders that she had, like seizure disorder, hypothyroidism. She was on n number of medications. So if you see the most important examination that we should focus on whenever there is suspected ocular myasthenia is pupil, right? So there should not be any kind of anisocoria or something like that. And once you are pretty sure, then you can always subject this patient for treating the strabismus. So look at this, how severe is the hypertropia. And no peri-orbital puffiness, no episcleral injection, no chemosis. That means, as we learn, the first slide, like according to the Rundle curve, the disease is pretty much in kind of quiescent. So we don't need to worry, and you can actually take this patient directly for the surgical intervention. So you can appreciate standard plus 9 gauge photograph, how gross extraocular motility limitations, especially the left eye elevation limitation, and very large hypertropia in primary gaze. So how to deal with this? Make sure that the thyroid profile is within the normal range. Endocrinologist has seen, and things are in place as we discussed. So then sometime all these patients, it's important to subject them for neuroimaging to understand what is the pattern which is correlating with what type of extraocular muscle enlargement. So as we can appreciate here, the inferior rectus and the medial rectus, in fact even the lateral rectus, they are enlarged. So that will help you to take a surgical decision of the same eye surgery. In addition to that, do you want to add any other extraocular muscle in the other eye, so that you can take care? So basically there are non-surgical and surgical ways to operate these patients. So non-surgical ways to control the thyroid hormones, cessation of smoking, intravenous or oral steroid depending upon the active stage of the thyroid eye disease. If required, immune modulation. Having said that, once the medical treatment is done, still these patients, they get debilitating diplopia to deal their day-to-day life. So you have other options, temporary measures, where until you plan actual surgery, you can offer them the different type of prisms, like slab-on prism, then the Fresnel's prism, or monoocular occlusion, or depending upon how much is the primary deviation. If it is a smaller amount, you can always offer the botulinum injection. So this is what the prerequisite I follow in my practice: 4 to 6 months of stable deviation, no signs of active TED, and stable systemic control. And that's the way to go for. If you want, there is an extensive the proptosis and strabismus in TED, then this is the sequence of surgeries that we should go about, like orbital decompression, strabismus surgery, and then the last one is the lead surgery. So this is we have recently published that, like, what are the strategic decision making when you deal the strabismus in thyroid eye disease. So binocular vision in a functional position of the gaze is a important the goal, especially the primary and the down gaze. That's what we utilize this gaze more often, and the expansion of the binocular visual field. So how to tackle? Let's talk about like hypertropia, IR recessions, unilateral depending upon the primary deviation, or a combination of the contralateral superior rectus recession. So I'll just take you through this particular case. So continue the systemic medication, get the fitness for general anesthesia, which is very, very important. These patients are very high risk, on table kind of the cardiac arrest and all. So you need to be very careful. Intraoperative FDT is again the most important test for strabismologists to look for, and decide your surgical doses and plan on table. So in this particular patient, ipsilateral IR recession and contralateral SR recession was planned, and you can appreciate that there was 40 prism diopter LHOT with 8 prism diopter exotropia. That's how the on day 1, and then day 8 weeks, I mean almost 2 months, you can see that there is a remarkable improvement in the hypertropia. However, these patients, when you tackle the IR, usually end up with getting the kind of lower lid retraction, which sometimes our plastic colleagues, we need to ask them to correct for the cosmetic purpose. So this is how the summary of this particular patient. So very gratifying outcomes. This is another case, a chronic smoker, already a hyperthyroid patient on treatment. Hormone levels were pretty good. However, he has developed very severe hypo and esotropia. He was on a treatment, and then you see the extraocular muscles. So IR and MR are extremely enlarged, and that's how they are pulling the eye down and in. So you need to, again, this very severe hypertropia and esotropia, so you need to subject them to the multiple surgeries, and you would find that they would do amazing if you have a very systematic plan their doses, considering many factors as we discuss, and on table FDT is a crux over a period of time. So you can appreciate this patient needed the second surgery, where the other eye SR was dealt, and you can see that the first and the last follow-up outcome. So they do good. What are the surgical challenge? Reoperation rate is little bit high. Recession is preferred over the resections. Whenever there is a large deviation, you can opt for standard nomograms. Are really unpredictable, the one which we follow for the routine horizontal or vertical surgeries. Post orbital decompression, this is the rule of thumb probably in my practice. Larger than expected recession for a smaller deviation, and smaller than expected recession for the larger deviation. As we know, the reason behind this, because the vertical fusional amplitude is somehow quite high in patients with thyroid eye disease compared to non-thyroid patients. So what are the precautions? Meticulous handling of the conjunctiva, because it's very friable and foreshortened, so you have to be extremely careful. Conjunctival closure, spatial hooks as and when required. Super tight recti, you need to use the Cowell hook to prevent the rupture or the pulled into syndrome on table. 15 number Bart Parker blade is also another option to disinsert the muscle. So A pattern horizontal deviations are more common. MR recessions aggravate. Keep this in mind. Be careful, watchful, explain to the patient before you go for surgery. In cyclotorsions, contralateral inferior oblique overactions, lower lid retraction, proptosis is a prominent. So there are multiple things you need to take care and counsel to the patient at the same time. This is another entity. Whenever you touch to the IR, be aware about the progressive overaction of after IR recession. So over a period of time, this patient might go into the hypertropia. So you need to be very, very careful, and understand like why does it happens, and that really helps you to, because it's always better to undercorrect and do the other ISR in case you want to tackle the large hypertropia, rather than doing extra large recessions and then post-operatively ending up with the hypertropia. So to conclude, the control of risk factors and stable endocrine status is extremely important. Avoid the surgical intervention during active phase. Strabismus surgery not before 4 to 6 months of stable deviation. And the goal is binocular vision in functional position of the gaze. Standard surgical nomograms do not apply. Keep FDT as a standard of care. Recession are preferred. Resections is large deviation. You can always take help. Progressive overcorrection, that you need to be keep in mind. Adjustable suture is another the viable option to tackle the diplopia. And chronic disease, long-term follow-up is needed. Thank you very much.
For a very well covered topic, covered the topic very well. I just want to ask one
Yeah.
question to you.
Yeah.
Do you prefer always an adjustable or conventional recession?
Yeah, I do the scleral conventional fixation technique in my practice. I usually plan to little bit under correct them. So if there are very large deviations, I bring them in a range where we can use slab of prism or Fresnel's prism. But somehow the vertical yeah, so in terms of millimeter, 1 millimeter in thyroid eye disease, I calculate it as a 3.5 prism diopter. So that helps me to
Do you go beyond 5 millimeter or
no, that's what for inferior rectus, I don't take that risk. However, like other recti, even superior rectus, I don't mind to go it like 7.5, because they don't affect even the visual field wise, because we are a little bit we have to be careful. If you recess more the IR, either I will go hyper, or the field of
is more
is
important?
more affected. So we don't want that.
So, and what type of suture do you like, vicryl or non-absorbable?
I use in my practice vicryl sutures. They do very well.
Because sometimes they say that
Yeah, they, if because of the weight of the muscle, sometimes they get cheese wire and
yeah.
go down. Yeah, that possibility is always
Do
there.
a nasal shifting of the IR to prevent torsional anything or
If like this particular case, there was kind of extortion in this particular patient, but it's not bothersome. So in until and unless like patient is complaining, tilting of image or something, I don't do it. But yes, that has shown that takes care of shifting would help. Yeah. Yeah, I mean, what I have tried actually, couple of patients, but in my experience, if you do a Botox alone, until and unless, it's a small amount of deviation, it doesn't help, right? If it is a large deviation and you just give a Botox, it's like nothing, no effect. If you are giving it accompanying the strabismus surgery, considering the large dose beyond the range of your surgical nomogram, then Botox add, and then you would get optimal result. That's how Dr. Granite's paper talks about. But that concept of like how come the Botox and the thyroid muscles, they are fibros, that is no more valid now. Botox do work in a patients with thyroid eye disease. Yeah, I mean that I have shown in one of the slides. So I have tried 2 to 3 patients, and it works actually to have the balance effect. So it's kind of a fed and of doing the contralateral IR. Yeah. Thank you very much. Oh yes.
Thank you, Dr. Shubhangi ma'am, for giving me an opportunity, and the scientific committee for making me a part of this interesting instruction course. Actually, the time is 12 minutes. I mean, by he's not able to change that. उसको 12 मिनट कर दो. Talk is 12 minutes. So I'll be presenting on Brown syndrome. I would like to. I'm sorry because I have to go to another session. So we'll start with the case of a girl, an 8-year-old girl. Her parents complained that there was some abnormal eye movement. They were not very sure what it is, but you can see there is some limitation in elevation in adduction in the right eye, and she has divergence excess in the up gaze. And in the right eye, it is quite obvious that she has got limitation in elevation in adduction. So usually in these cases, you have to look down also, so that to see for any ipsilateral overaction of the ipsilateral antagonist. So because there wasn't, it definitely was a kind of a restrictive strabismus. Sharing another case,
देखना है उंगली की तरफ। अच्छा, इस तरफ देखिए उंगली की तरफ।
the above movement, she had you can see that she has got a downshoot on attempted adduction in the left eye.
इधर
And
देखिए
definitely
ऊपर।
there was
हाँ,
limitation in
ऊपर देखिए छत की तरफ, गर्दन नहीं हिलाने से। अभी मेरी ये वाली उंगली की तरफ देखिए, इधर देखिए नीचे।
in the right eye also, similar feature in the right eye. With limitation in elevation in adduction. So
इधर देखिए ऊपर।
additional
बहुत
feature was she had a downshoot. So there was limitation in elevation in adduction with mild to no limitation in elevation in up gaze, whereas in abduction it was normal. Some patient, like the second case, had a downshoot. Your patient might present with a V or Y pattern. In addition to that, the patient, some patients, if they develop a hypotropia, they will have a chin up posture. Palpebral fissure changes, the way we get in Duane's, are less likely to happen in Brown's. So coming to Brown syndrome, the basic, it was originally called superior oblique sheath syndrome because it was believed that the sheath, I mean the functional origin of superior oblique is from the trochlea. So the sheath beyond the trochlea was supposed to be affected, but Dr. Harold Brown found that it was the entire muscle was tethered, so entire tendon beyond the trochlea was tethered. It's after him that this syndrome is named. It's more common in females, and around 90% are unilateral, but both the cases which I showed were bilateral actually. The most common differential diagnosis is a paretic variety, that is inferior oblique paresis, because the limitation in elevation can happen in inferior oblique paresis also. The basic difference between a restrictive and a paretic strabismus on ocular motility is the overaction of the ipsilateral antagonist, which doesn't happen in Browns, but in inferior oblique paresis you will have a superior oblique overaction leading to a pattern, And of course, force reduction test will help you to differentiate. Around literature has found that around 16% cases of Browns might have improvement or remission with time. So how to do a force reduction test for oblique? Actually, we need to make the tendon taut by pressing the globe down, so that tendon becomes taut, and look for excyclotorsion and encyclotorsion. In Browns, the excyclotorsion part will be difficult to be done because the superior oblique doesn't allow that to happen. Brown syndrome can present with horizontal squint like esotropia. If there is no, a chin up or any abnormal head posture, Brown syndrome may not be tackled at this stage. Or sometimes with exotropia, like in this girl, she had a bilateral Browns in addition to exotropia and also abnormal head posture. You can attempt both the correction of the horizontal as well as the Brown syndrome as well in these cases. Sometimes Brown syndrome might have, in addition to the downshoot, there might be limitation in elevation in upgaze, but it's definitely more marked in adduction, whereas the abduction part is normal. So this helps in differentiating it from the monocular elevation deficit, where all the upgaze positions are limited. So the basic management plan for this condition: any patient with a limitation of elevation in adduction, do a force reduction test to find out whether it is a restrictive variety or a paretic variety. If it is negative, we think in terms of inferior oblique paresis. If it is positive, either it can be Brown's, rarely it can be orbital floor fracture or a thyroid related orbitopathy also. Coming to Brown syndrome, which is congenital, acquired, and iatrogenic. Iatrogenic is because of excessive tuck in congenital superior oblique palsy. So in these cases, we need to explore the tuck. Acquired can be traumatic or it can be inflammatory. If it is traumatic, we do the surgical exploration. If it is inflammatory, orbital inflammations, either treated with steroids or a non-steroidal agent also. Congenital type is the most common. It can be with a normal head posture or an abnormal head posture. If there is no abnormal head posture, better not to touch these muscles, touch these cases. Abnormal head posture which is stable for a prolonged period of time can be considered for surgery, and these are the two commonly done surgeries in this case, in Brown syndrome. The problem with Brown syndrome is that it is a restrictive squint. So every restrictive squint is a variety of its own, so you have to individualize the case. Also, it is a superior oblique, which in olden days was never touched by, or not touched by, many of the strabismologists. The problem with superior oblique is that it usually helps in down gaze, which is most functional part of our gazes. So if you try to weaken it, in case of Brown syndrome, it might give a picture of a superior oblique paresis. And if you like to strengthen it by doing a tuck in a case of superior oblique palsy, we might have a Brown syndrome. So you need to explain these, counseling part to the patient beforehand. Except for the name oblique, there is no similarity as far as surgical point is concerned between superior oblique and inferior oblique. So if you are contemplating a surgery for Brown syndrome, try to avoid it as much as possible. If there is no abnormal head posture, consider only if it is abnormal head posture without any sign of remission. Set the realistic goal to the patient that it is mainly to correct the head posture, and actually this part applies to all squint surgeries for restrictive strabismus, that head posture is what we need to correct, and ocular motility might improve but not completely correct itself. There are chances of diplopia, especially in down gazes, which might need prisms later on. And final decision making especially is done after doing the force reduction test, which is done on table. Most of them are children, so doing FDT in OPD might be a difficult proposition. So the weakening procedures are the tenotomy. Still, I think it's the most commonly done surgery because of the ease of doing it. But more titrated procedure like silicone band or a non-absorbable suture can be used. This was a patient who had exotropia with Brown syndrome. She had undergone a congenital cataract surgery early in childhood. So this was a right eye. I'm showing a video of a tenotomy. Before doing the surgery, we do a force reduction test to see how much amount of tight the superior oblique is, and then we hook the superior rectus muscle, stabilize it either with a Jameson hook or a Green's hook, and then we need a proper exposure. And hooking the superior oblique is a bit tough because it is tight, and superior oblique lies posterior to the superior rectus muscle. So we might have to do a posterior tenotomy with proper exposure, either using Demars retractor or Barbie's retractor. And then we see the superior oblique fibers, which are glistening white fibers under the superior rectus, and the hooking part is a bit tough. So ensure that you have hooked all the muscle fibers, because otherwise the effect will not be there. Usually temporally the tendon is small. It is nasally that it is more fanned out, and once it is hooked, then it's up to you what we have to do. So there are surgeons who do Z tenotomy. Some surgeons do only the cutting of the anterior fibers of the superior oblique. But when you have to do a free tenotomy, you can simply cut the muscle. The important part is after cutting the muscle, do a force reduction test to see how much amount of effect this procedure has actually achieved. So I would like to thank Dr. Shubhangi ma'am for this particular video. I'll share this video later on. Actually, there is some technical problem. So this is a video of tendon expander. So we go to the next slide. Superior oblique tendon, what literature says is that superior oblique tendon sheath syndrome is not the name anymore. Though clinically we suspect Brown syndrome, many clinicians feel that FDT may not be necessary to diagnose the condition, only when we were contemplating a surgery. Spontaneous resolution can occur, and though according to Kenneth Wright, superior oblique tenotomy is the preferred procedure, tendon expander might provide more titrated results in these cases. So Brown syndrome is an important restrictive strabismus. Congenital variety is most common. Majority of the cases do not need treatment. Treatment should be considered only if there is no further improvement with time and patient has an abnormal head posture. And the more commonly done surgery even today is superior oblique tenotomy. So always set realistic goals to the patient whenever we are advising or planning a surgery. I'll just share the video of the tendon expander. Yeah. We go nasally, superior nasal in these cases, and we use 5-0 Mercilin or 5-0 Ethibond on both the sides of the superior oblique. You can before actually cutting the muscle, ensure that when you are cutting, the inferior sheath of the superior oblique is not cut, so that whenever you are passing the 240 band, it does not touch the sclera. Otherwise it will behave more like a belt buckle and less like a silicone tendon expander. So also chances of extrusion are less whenever we are whenever the sheath is preserved. So this is more titrated and more predictable result compared to a free tenotomy of the superior oblique. Thank you. Thanks.
Thank you, Rishi, for a wonderful talk. I just want to, do you want to ask anything, Suma? Yeah. Hypotrophy. Yes, palsy. Troublesome. Browns.
Yeah.
Hmm. Yes.
Actually,
And even about the tenotomy, what you said is anterior fibers. If you just cut the anterior fibers, then it will just correct the intorting effect, because tendon which is on temporal side, anterior 1/3 is responsible for intorsion and posterior 2/3 for depression. So in order to get that effect, you have to accordingly recess that particular part. And one thing is, after the surgery for Browns, never expect an improvement in elevation in adduction. That may not happen. We are just interested in correcting the primary position hypotropia.
Counseling is most important to parents, that the elevation may not improve even after the surgical correction, because most of them feel that it should improve. So very nicely covered. Yeah.
Any Maza talk something. Duans.
Yeah. Now I would like to introduce our main chief instructor, Madam Dr. Shubhangi BHAVE. Actually, she needs no introduction. She has been doing 40 years of service in pediatric ophthalmology and strabismus. And she is a GMC Nagpur alumnus. She has published in various national journals. She is recognized as a postgraduate teacher by Nagpur University, president of Nagpur Academy of Ophthalmology 1996 to 1997, president of Vidarbha Ophthalmic Society 2006 to 2007, then scientific committee chairman VOS 2010 to 2013. She is a life member of various ophthalmic societies, the member of scientific committee MOS 2011 to 2013. She is practicing at Drishti Eye Clinic and Squint Center. It's her since 1994. An organizing chairman, MOSCON, and now President SPOSI. Welcome, ma'am, and I think it'll be always a wonderful presentation. I know that.
Thank you, Suma, for those kind words. Me and Suma are sharing our topic today. I'll be talking about clinical manifestations and treatment strategies and Duan's retraction syndrome. So there's bound to be some overlap in both our topics, but I feel Duan's is such a topic that it needs to be covered by more speakers. So I'll just shortly run through the introductory slides. DRS is a complex congenital restrictive strabismus included in the category of congenital cranial degeneration syndrome. Incidence is 1 to 4 in general population. There's a female preponderance. Unilateral is more common, 80% the left eye being affected. It is characterized by variable limitation or absence of abduction, a variable restriction in adduction, retraction of the globe with up and down shoot. We all know that it is due to the innervational anomaly of the LR. It is also innervated by the branches of third nerve. And the clinical scenario mainly depends upon how much normal or abnormal innervation LR receives and at what position of horizontal movement is the abnormal innervation initiated. And EMG also demonstrate different degree of anomalous innervation to LR in adduction and synergistic innervation with MR, SR and IR. So we all know about the Huber's classification, type 1, type 2, type 3, but clinically I feel it's easier to classify them as ESO, EXO or ortho DRS. Now this is a case of or ESO-DRS. You note the abnormal head posture, which is mainly face turned to the left side. On undoing the head posture, there's not much of deviation in the primary position, and there is a retraction and narrowing, but when she takes up fixation with the left eye, there's a large esotropia in the other eye. And there is a retraction and narrowing in adduction, and there is a deficient abduction about grade 3 to 4. So this is a typical feature of Duan's, that the primary position deviation does not match the degree of abduction deficit or movement deficit. Now this is a case of again a female with left eye Duan's, and you see the amount of abnormal innervation by the pumpkin seed sign seen in the adduction, and there is a abduction deficit. So it tells us about the large amount of anomalous innervation of the LR. And now this is another case which is has a orthotropia in the primary position. But there is a unsightly lid retraction and narrowing on adduction. So sorry. Anyway, so that is what I wanted to just tell you, the clinical types of Duan's. Certain examination tips that help us in management. One has to carefully evaluate the is the present. Did you move? No. Okay. So careful evaluation of ductions while the present patient maintains a neutral head posture is important. Assessing the amount of globe retraction, with this correlates with the amount of anomalous innervation. Looking for adduction abduction deficits and patterns and ups and down shoots is important. Abduction deficit, we all know, is due to lack of innervation to LR, or could be due to contracture in MR, and this can be differentiated by the FDT and FGT. Adduction deficit, which is seen more commonly in type 2 and type 3 of Duans, is largely due to large amount of anomalous innervation received by LR in adduction and can be assessed by force degeneration test of Ramiro-Apis, in which the patient is asked to look midway between primary position and full adduction. Temporal limbus is grasped and patient is asked to adduct the eyes. If the resistance is felt, that means the lateral rectus is getting innervation in adduction. Then we have to measure the angle of deviation. One has to control the fixating eye during alternate cover test, and DRS is associated with numerous ocular and systemic anomalies, hence a thorough ocular and systemic evaluation is needed. Now coming to the tips in managing ESO-DRS. We all know that in ESO, LR has a minimal activity in abduction and has an anomalous action in adduction. So one has to check for MR contracture by doing an FDT. One does a minimal MR recession on the side of DRS, especially if co-contraction is more. Otherwise, it will result in adduction deficit and diplopia in that case, or if the anomalous innervation is more, even in synergistic divergence. Now this is a case who presented to us with a left ESO-DRS. You can see the head posture, primary position deviation, there's narrowing on adduction, and on abduction there's a grade 4 deficit with hypotropia. So she was subjected to left eye MR recession of 4 millimeter and inferior rectus transposition to the lateral rectus, and combined with MR recession of 6 millimeters in the right eye, which corrected her head posture nicely. The primary position became straight, the retraction became less, and we could get about 15 degrees of abduction, and the hypotropia also was corrected. Now this is a small video of superior rectus transposition. Here we are, after clearing the muscle, we are putting an vicryl sutures to the superior rectus muscle, and then the LR muscle is hooked. And we are putting an Foster suture 8 millimeters behind the insertion using a ethibond, and the SR is inserted alongside of LR in along the spiral of Tilo, and then the Foster suture is tied. Coming to the EXO-DRS, there is an abnormal innervation to both MR and LR. One has to estimate the co-contraction, estimate the LR activity. Exotropia associated with a normal activity, one has to tackle LR by recession. Exotropia associated with up and down shoot and retraction, one needs to do a Y-split of LR with recession, or supramaximal recession of LR, or periosteal fixation of LR, depending upon how much is the anomalous innervation. And always remember, there's other eye which can be operated. Now this was a girl who again had a EXO-DRS in her left eye with a large head posture to the right side, and she had a retraction and narrowing on right gaze, and but if you see, her LR activity is good and there's not a significant anomalous LR activity. So what we did was, we did a LR recession of 8 millimeters on left eye with a Y split done 20 millimeters apart, and LR recession of 6 millimeters in her right eye, which corrected her head posture and corrected primary position deviation. The retraction also became less, and we did not alter her abduction in the left eye. Now versus that, if you consider this case who has a severe anomalous innervation of the LR, this case might do better with a periosteal fixation of the LR muscle. Now, a small video of Y split. The lateral rectus is hooked, and I use a iris repositor to split the muscle for about 15 to 20 millimeters behind. Actually, the uploaded a old video of mine. Anyway, and basically both the slips are we put an 60 vicryl on both the slips, and the muscle is sorry. So after putting the sutures, I split them upon, I take a center mark, and then 10 millimeters above and 10 millimeters below, we attach the two slips at whatever amount of recession we have decided on. So that is how the Y split stabilizes the eyeball and prevents the slippage of the eyeball in adduction, thus reducing the up and down shoot. Coming to the ortho DRS, just last two slides. The main important is not to disturb the primary position parallelism. If there is significant retraction on adduction, then one needs to operate. We can do differential recession of both LR and MR, preferably one muscle on adjustable. If there's an up and down shoot significant, then Y split of LR with MR recession on adjustable. So this is the case which I had shown previous of ortho DRS. We did a differential recession of MR and LR with MR on adjustable. So the primary position ortho was not disturbed. There was a reduction in narrowing and a retraction of palpebral aperture. So take home points are DRS requires a tailored treatment in each case. Thinking cap needs to be put before deciding surgery in each case. Avoid resection of muscles in DRS. Small MR recession on the side of DRS is advisable, and proper patient counseling is the key to a satisfied person. Thank you.
Any questions? I think we'll take the questions after both the talks for DRS together. And it was a wonderful presentation, and I think my topic, most of it has been covered. Let's.
Yes, again that depends upon amount of anomalous innervation of LR. If it is a too severe retraction with a pumpkin seed sign or severe ups and down shoot, it indicates lot of anomalous innervation to LR. In that case, then we can preferably do a periosteal fixation too of LR muscle. Yeah, with this, I invite Dr. Suma Ganesh, my dear friend, who has kindly consented to participate in this IC, and she will be talking on surgical management of Duan's case-based approach. So Dr. Suma is Director of Pediatric Ophthalmology and Strabismus at Shroff Charity Eye Hospital, Delhi. She has done fellowship in Pediatric Ophthalmology and Strabismus at Manhattan Eye and Ear Hospital. She is awarded SD Athavale Award for Best Paper of Squint in AIOS in 2003 and has received the prestigious AIOC Award for her work in Strabismus in 2012. Has huge number of publication, 111 to be in fact to her credit, and is currently working on childless blindness project with Orbis, Seva and Perkins International. And she is a very good teacher. So, Suma, your topic.
Thank you, Dr. Shubhangi ma'am, for the invitation, and nice to be part of this IC. And also thank you, IIOS, for giving us this opportunity. I think my topic has mostly been covered by ma'am, but I'll just go for surgical management of Duan's retraction, a case-based approach.
12 minutes. Make it 12 minutes. Each talk is 12 minutes.
Yeah, that's what even I thought for your talk it was less.
Acha, they hadn't put over 12
No,
minutes.
I think it was
Okay,
10.
yeah.
So this nicely madam has covered, Dr. Shubhangi has nicely covered. It is basically the Duane syndrome is an absent or partially developed abducens nucleus and nerve. So basically most of the problems are with the lateral rectus. This has been proved by a lot all the time, and that's why we need to, whatever tackling we have to do to the lateral rectus. The branches of the oculomotor nerve are redirected to the lateral rectus muscle. So now it comes under the terminology of CCDS. So the management, basically there is an abnormal head position, abduction deficit, there could be an adduction deficit. Then we have to see the amount of retraction, if there's an upshoot or a downshoot, primary position, what is the deviation, and unilateral and bilateral and fusion. So this means whenever because basically now if you have to go for a publication, so we need to say how to say that our results have become better. So we need to grade our globe retraction so that we can say that it has improved. So this is how we grade that. We take it from, we make the eye adducted position in the normal eye, and then we measure it along the limbus, and we see this is the 12 millimeter and this is 12 millimeter, and see here in this case it is smaller, that's 9 millimeter. So you take it, compare it with the normal eye in the position, and we can see here also it is grade 2 globe retraction, and then you have the pumpkin sign or the grade 3 globe retraction of 73%. So this is how you grade it. It is given in a publication by which is published in JAPOS by Dr. Shailaja Tibrewal et al. Same way they have also graded the upshoot. So this is all for publications. Basically it's a line drawn from the pupillary center of the normal eye, and when we do the surgeries we want to know whether the upshoot has been corrected or not. So this is how we plan. We say that the line between the drawn from the pupillary center of the normal eye, and we say how much is it between the pupillary center and pupillary margin, or between the pupillary margin and limbus, and or the cornea disappears below the lid. That is grade 4 or the pumpkin sign. So we have a case here of a 24-year-old male not able to move the eye. So this patient could not move the eye. So you can see that there is severe globe retraction, and this is a pumpkin sign, and also there is a grade 4 upshoot. So now in this case we have to tackle the abnormal head posture, the deviation, and also, so if you see here the deviation is around exotropia of around 20 prisms, much less than expected. Then right hypertropia, which was around 20 prisms, and we found that there was a phase turn to left side of 110 degrees, grade 4 upshoot on adduction, and then we also found severe globe retraction. So when we consider all these aspects, that is how we come to the surgical management. So now we know that it's a type 3 Duane's. Now we have to see, we have to correct the head posture, we have to correct the exotropia, we have to correct the head hypertropia, and also the upshoot and downshoot. So there was in the MRI suggestive of absent abducent nerve nucleus. I just wanted to check on the inferior rectus. That's why I got the MRI done or be done, because I wanted to see whether, because there was severe globe retraction and vertical deviation, I just wanted to check whether there was an inferior rectus present or not. It was present, but there was hypoplasia, though I didn't know, we didn't get it so much on the when we're doing the surgery. So this is a globe retraction which we see on adduction. All my videos are getting turned, I don't know why.
Slowly.
The severe globe retraction. So this sign has been said by the Eisenberg and Urus. They have documented this sign that there is drooping of the upper lid along with elevation of the lower lid in about 52% cases of Duane's. Just a sign, and I felt because this patient of had this, so I thought I'll take a video of this. So this has been published. So this, so we thought like, okay, now we have a exotropia type 3 DRS with hypertropia with combined mechanical and innervational upshoot. This we got an FDT which is tied for a medial rectus, lateral rectus, and superior rectus. And in this case, we planned a lateral rectus recession with a Y split. So for a 20, we all know that the exotropia we have to correct. It is, you have to do large amount of lateral rectus recessions because it is 1 millimeter for 1 diopter. So we did a lateral rectus Y split. I use the small hook for the splitting of the muscle, and then we have to split it So I think the video has already been shown of the Y split. So the most important thing in the Y split is that for recessions, and also that we have to keep them around 20 millimeter apart. So that is what we say that. So if you measure it, the 10 millimeter is a point at both the edges of the 10 millimeter where you have disinserted it. You go down there and mark the. Now I'll just show you to you. You mark there. So go down here and you mark, see here. This is 10 millimeter. And so when you take your full, that means it is 20 millimeter apart, because the 5 millimeter of the muscle of each split. So this is what it mentions in Rosenbaum, that you have the muscle which is 20 millimeter apart, and then you suture the conjunctiva. So post-operatively, he is very good. He had no face turn, upshoot, and globe retraction also was reduced. So if you have to have a publication, because we send this for publication, so you need to measure, tell them how much your globe retraction or your upshoot has reduced. So that's why that measuring it is important. Case 2, also a 6-year-old child with an abnormal head posture and squinting of eyes since the age of 1 year. So we found an extorsion on the fundus in the left eye. So this was again an exotropia of 18 prism diopters. She had a left hypertropia of 6 prism diopters, but there was very minimal globe retraction. Left, there was an upshoot which was on adduction, but this upshoot also we can, if you grade it, it's around only grade 1. So now how do you, how, and when we found, when you have the video, we found that it was a gradual shifting of the eye. So it was a left hypertropia with only 6 prism diopters, and which increased on, when you've seen in the, if you see in the dextro version, you find that it has increased. So the measurements also of your exotropia has increased. So this fitted into our innervational upshoot. So what we find, there are 2 vertical movements in DRS. One is a mechanical, where it is abrupt up and down movement, and you have a gradual elevation and depression, which is innervational. They have a vertical deviation in primary position. So this is how we differentiate from a, so suppose if you have a vertical deviation in primary position, mostly we find that these are the cases which is the innervational type. So Mohan et al. Have found that the mechanical type to be more common, but this was a case where we had a innervational upshoot, and that is why I presented it, where we have done an inferior oblique myectomy has been described by Avadin, but for the mimicking the inferior oblique overaction. But in this case, I did a recession. I don't do myectomies. So I did a recession of 3:2, the Park's method, and a recession of the lateral rectus of 16 millimeter, and which gave me a good result. So this is how we plan whether we have to do an inferior oblique or whether we have to do a so then this is the other case. Again, these are all DRS with vertical deviations. So that is why it is so important to measure in all gazes, because it gives us a clue what we are dealing with. It is not only important in primary position. So we have here we have a hypertropia here of 40 prisms, exotropia of 25 prisms, and this we found that the hypertropia increased in the ipsilateral position. So we suspected a ipsilateral superior rectus contracture, and that's exactly what we found in FDT when we took up the patient, that there was an ipsilateral contracture, and we operated the patient with a, but still there was a residual of around left hypertropia of 14 prisms. Patient was doing well because it was under local, so we operated only one eye. So we did an exotropia LR recession with a superior rectus recession and a Y split because of the upshoot. The patient is doing fine. Not come back for a resurgery, but may come back later for a resurgery because there is still small amount of left hypertropia. So this is a 25-year-old male with an inward deviation of left eye since childhood. So there is a turning of the face while reading is the complaint. So she was 25 esotropia for distance, and for near it was 20. There is mild globe retraction. So now and decrease in palpebral aperture left eye on in adduction. But if you see, it is very mild cases. So now these are the cases when you have mild but with a -5 adduction deficit, where you could try a superior rectus transposition. So we have to understand the cases. So we do not do superior rectus transposition in all cases. You may land up with more problems then. So you do it in such selected cases where you have minimal globe retraction. So superior rectus transposition, when you combine with medial rectus recession for Duane syndrome, so it will correct an esotropia up to more than, if it is more than 15 prism diopters, you need to do a superior rectus transposition and a medial rectus recession. But if it is less than 15, you can get away by doing just a superior rectus transposition. And it has not, in this paper at least, it has showed that there is no torsional diplopia. And in the few cases which I have done, there has been no vertical deviation or no torsional, but it depends on the case selection. So I think she has already shown the video of a superior rectus transposition, just a small video. And so in this case, we did an SRT with 4 millimeter recession. So these, how much to do and all is given in. So I've done a fornix incision. So fornix incisions are when you have to do a superior rectus transposition is better. And once you isolated the superior rectus, then you transpose it to the so whenever you are transposing any muscle, you need to dissect the muscle a lot. That's what we need to, and because we need to dissect the muscle up to around 10 to 12 millimeter behind. Otherwise, the muscle you'll not be able to shift the muscle, and even your effect of the muscle won't come. If you don't cut it, you don't cut up to around 10 to 12 millimeter, at least the check ligaments and the intermuscular septum, and then you shift the to. Since I had also a medial rectus recession, so this I have shifted it to the lateral rectus. So this is superior rectus transposition of the. So you can see the muscle easily is coming to there. That is because you have dissected so far off. Otherwise, you find you're struggling pulling the muscle towards the lateral rectus. So this is the superior rectus transposition of the muscle. And then so you take it around 8 millimeters from the spiral talus. Okay. So 1 minute is there. So these are the post-op pics of the patient. Now you have another patient. So this is again a small esotropia with small face turn with minimal globe retraction. So in this case, I did only a SRT because 10 millimeter, just 10 esotropia, and the patient wanted that his abduction improve slightly, and he was concerned about. So in this case, we did only a small SRT. We did SRT, superior rectus transposition, and it worked. So it is all on patient selection and the management strategy. So I have not done an inferior rectus transposition. I was tempted once, but I have not done it yet. Because they say it can be advantageous in patients with an A pattern, with a V pattern if you do an IRT, and it is more SRT can be more advantageous in patients with an A pattern. But I have not done for a case of IRT for any case. So this is a simple case of 25% where you do a medial rectus recession, and this is an exoduance which ma'am has nicely covered, where it is 40% for distance and here, and for distance, and you do a lateral rectus recession with a Y split. So in these cases where you have so in large XL exo DRS with downshoot, this cases I did what I did was basically a large recessions of lateral rectus. So I feel that more than, because not a severe upshoot and downshoot was there, so I did a large recession of the, and this is orthotropia where again I did a differential where again like as ma'am said that it is our recession with a MR recession of this. Now the last slide, which is a type 4 synergistic divergence. I would do only lateral periostal fixation for such cases. I would not do for other cases of exo DRS. This has been my learning, and I prefer my lateral periostal fixation to third nerve palsy, and also to cases of like the synergistic divergence. So I'm not sure, has Dr. Barsha pointed, I'm not sure whether it will be effective when there is an upshoot and a downshoot. Though I think logically it should have an effect, but
Yes.
I'm not very sure. So because the abnormal innervation, but it should work, I think.
Yeah, I think
I'm
it
not
should.
done, so I don't know. So I prefer only in synergistic divergence in Duans and in cases of third nerve palsy.
Thank you, Dr. Suma, for, as usual, a talk which teaches you the basics and beautifully covered it. Anyone, please, any questions on this topic so that then we can go on to the last talk? Yes.
More than you combine it with a medial rectus recession. So what's your long-term experience in SRTs? Because I have seen they tend to have a little overcorrection with time. Do you have that experience? So I'm a little hesitant in doing that MR recession, especially in smaller children, because I've seen over the time they have a tendency to go for a little exo. So I just want to know, how do you titrate? And I also want to know when do you do a Foster's augmentation and the technique of augmentation, because there are different techniques in which some people just tie the muscle together. There are some techniques in which they advise you to do a scleral bite also. So what's your experience and when do you recommend this?
So what I would say is that SRT, what you are saying is that if you do an SRT combination with a medial rectus recession, you have found an overcorrection.
Yeah, but I think the ones I think I did a Foster's augmentation also with that, but the angles were larger, of course.
Yeah.
It was about 40 And but
See,
the MR
whenever there
recession
is a very
small.
large angle, no, like see in these cases, when suppose if it is like 30, well, mostly 30, 35, they don't come up to very large angles in ESO. At least I've not seen very large DRS
Yes.
deviation. In maximum, I think I've seen is 35 or 40. In those cases, mostly I prefer to do a bimedial recession, frankly speaking. I don't do an SRT unless it is one eye, and like when if I, because SRT, I leave it very, very few cases where, where I find that the deviation is less,
Abductions, huh.
and there is, and there is good adduction, and you have an mainly only an abduction deficit, and the globe retraction, upshoot and all not there at all. So actually those are very rare cases. Like so.
So no
what,
retraction, no upshoot.
Yeah. Then those are very rare cases. In those cases, I prefer like if SRT I've done is mainly for 2025. I have not found overcorrection because then in those cases, medial rectus I've only done 4 millimeters.
Do a less.
Less
Why I
amount
said
of-
is because there are some papers which compare it with LR palsy. Like
Uh-huh,
they
yeah,
say that in LR palsy you hardly get an overcorrection, but in DRS, unless you're careful, you can get an overcorrection when you combine it with an MR recession.
So
I
the
just wanted
MR
to-
recession only has to be as much as to reduce the contraction,
I've
the
started
FDT,
reduce- yeah, I've started
release the
reducing to
FDT.
hardly 3 mm. Maybe very
3.5 is
and
also
I sometimes
good enough.
find that even that produces some adduction
Yes,
deficit.
yes.
So I'm like, I'm just wondering whether I should
That is
do it at
because
all.
we are not doing away with LR abnormal innervation. LR abnormal innervation continues even after Y split or recession or whatever.
But alone SRT, in 2 of my cases didn't work. So, this boy had very minimal, so 10 prisms, so that's why it worked. But otherwise, I found that if like even a patient of around 15 to 20, I thought let me do 15 to 20 it was. I said only do an SRT because the tight contracture of the medial rectus, the abduction did not improve at all. I had
Actually,
to go back
only-
and do a 3
yeah.
millimeter MRSS.
Only if the FDT
Yeah,
is
so
negative,
Only the FDT is negative.
then
it's like it
maybe
works.
SRT alone would
And
help.
sometimes you give this midway FDTs, isn't it?
Yeah.
Like, so then also I do a small MR recession because you really don't know whether it's going to work or not. Thank you.
Yeah, and the Foster suture you were saying, normally I take the Foster suture attached to the sclera, but some people attach muscle to muscle also. But to me, if you attach it to sclera, it would have a better effect.
But does it produce torsion? Because there are some studies which says that with torsion has been a concern when you attach it to sclera rather than when you just put.
I have not found any
experienced.
torsion. So with this, I request our last speaker and my dear friend Dr. Varsha to present her talk on restrictive strabismus following adherence post-traumatic post-RD surgery. Dr. Varsha has done her MBBS MS from IGMC Nagpur. She was lecturer in Department of Ophthalmology GMC Nagpur for 6 long years. She has a special interest in squint, has participated in many squint surgical camps, conducted instruction courses on squint in AIOS, MOS and Vidarbha Ophthalmic Society, and is an invited guest faculty in National Strabismological Society of India, MOS and VOS. She was president of Ophthalmic Society of Nagpur, scientific committee member of VOS and MOS, and at present practicing at Netra Sanjeevani Eye Hospital and Squint Center, Nagpur. Dr. Varsha.
Thank you,
12
Dr. Bhave.
minutes, make it. Yeah.
Thank you, Dr. Bhave, for the opportunity and for the introduction. I'll be talking on the restrictive strabismus following adherence, post-trauma and post-RD surgery. As we all know, restrictive strabismus is a form of concomitant squint where there is limitation of movement out of proportion to primary position deviation, and it usually causes troublesome diplopia. It is very difficult to treat and cure completely. I'll be talking about the acquired cases of restrictive strabismus after orbital trauma and for fibrosis post-RD surgery. So in restrictive strabismus after orbital trauma, the signs and symptoms they vary widely. They may be very subtle to severe. They may present early or late. to us. The early presentation, the diagnosis is difficult due to the associated findings like black eye, orbital swelling, and there may be restriction of movement, not because of restriction but because of pain. Patient may not move his eyes. And the late presentation after edema subsides, the diagnosis at this stage is easy as proper clinical examination is possible. And the differentiation between restrictive and parotic strabismus is necessary at this stage, and the treatment varies. So post-traumatic restrictive strabismus is caused due to direct muscle injury, which may be avulsion, rupture or laceration. There may be orbital fracture with muscle entrapment, and swelling and scarring around the globe may cause restriction of the muscles. I will be dealing a case of each. So in the evaluation of these cases, complete anterior and posterior eye examination is essential to rule out the associated penetrating injury, visual acuity, pupil reaction to rule out the traumatic optic neuropathy. Then we have to assess the degree of limitation of movements, muscle functions and conditions of the surrounding tissues. Ductions and versions are very important. We have to look for primary and secondary deviations. Diplopia chart, His chart, FDT to know the restriction, FGT to know the contractile power of the muscle. CT scan and dynamic MRIs are definitely helpful to confirm the diagnosis. While doing the routine cover test, one point one must remember in cases of restrictive strabismus that occlude the each eye long enough to take up the fixation, because patient may not want to move the eye due to pain and not only due to restriction, as I said, and there may be poor vision or field defect which may prevent the fixation. Then the saccadic velocity evaluation in restrictive strabismus eyes, it will make fast saccades up to the limit of restriction and then stops abruptly. In parotic strabismus, usually eye will move with subnormal or increased latency, so slow excursion, floating saccades. Force duction test already been discussed. It is important we ask the patient to look in the direction of restriction of the eye movement and we can feel the tuck and restriction. Then general principles of management of orbital trauma in cases of restrictive strabismus. After clinical examination, if the CT scan confirms the diagnosis and if there is intact or parotic or minor muscle injury, we can wait for 6 months and see for the spontaneous recovery. If there is fracture with entrapment, then surgery is indicated. Muscle is lacerated or avulsed, then we can do retrieval, can be tried by the conjunctival approach if it is located anteriorly, and by anterior medial orbitotomy if it is located deep in the orbit. Damaged muscles if not found, then later on we can think of muscle transposition to correct the strabismus. This is a typical case of orbital floor fracture where there is periorbital ecchymosis, restricted elevation, enophthalmos, and other features may be abnormal head posture, restricted depression along with elevation. There may be sometimes emphysema causing exophthalmos. Then the infraorbital nerve anesthesia may be there. His chart showing typical the restriction of muscle because of the inferior rectus entrapment in the orbital floor fracture. Then the confirmation of diagnosis is by the CT scan, which is the best method to locate the typical blowout fracture, where the orbital floor gives, you can see the orbital floor giving way to the orbital contents, fat, fascia, inferior rectus muscle prolapsing in the maxillary sinus. Sometimes the orbital margins may remain intact and the floor fracture may be associated many times with the medial wall fracture in some cases. So in cases of management of orbital fracture, general principle, after confirming diagnosis, timing of the surgery is important. Surgery can be delayed 2 to 3 weeks if the edema resolves, but should be as early as possible to have better effects. And it is indicated only if there is a large floor defect, enophthalmos, troublesome diplopia and abnormal head posture. And that can be tackled by the subperiosteal approach. The muscle is freed and it is sealed with the supramid sheath, and we have to confirm that FDT is negative at the end of the surgery. So this is a first case I will be showing. The 20-year-old female with history of road traffic accident 1 month back and presented with diplopia and squint since then. Immediately post-trauma, she had lead edema, conjunctival congestion, painful eye movements and diplopia. But the acute symptoms were relieved by antibiotics, but she was referred for persistent diplopia after 2 months. In the primary position, there is small exotropia of 8 to 10 PD, severe restriction of the medial rectus, you can see here. The eye is not moving beyond the midline, and rest ocular movements were full and painless. Horizontal diplopia in the maximum in the left gaze, and FDT was positive for MR. So this is the H chart, diplopia chart, and the CT fracture showing the fracture of the medial wall, and there is a avulsed medial rectus entrapment in the ethmoid sinus. So in this case, this indication for surgery were diplopia and strabismus. This was done by our oculoplasty friend at Nagpur, Dr. Changule, and he did transcaruncular approach to medial wall. Medial rectus was identified, released, and porous epithelial implant was placed, and post-FDT, post-operative FDT for medial rectus become negative, and she was relieved of diplopia and primary position strabismus. Patients with medial wall fractures may present with varying motility and with limitation of adduction and abduction both, and asymptomatic cases may be there in case of medial wall fracture. So, but most important thing, blowing of nose should be avoided in such cases to prevent the further deterioration.
राइट साइड में देखिए, राइट साइड में देखो, अब धीरे से लेफ्ट साइड में देखो, देखो पूरा लेफ्ट साइड में, फिर से राइट साइड में देखो, फिर से लेफ्ट साइड में देखो, अब ऊपर देखो, अब नीचे देखो, अब बंद करो आप, अब खोलो.
Congestion, the movements were painful. And the post-op, same patient, thereafter correcting the movements recovered fully.
इकडे पहा पूर्ण.
There was no strabismus.
डावीकडे, उजवीकडे, उजवीकडे आता वर, खाली, वर, इथे पहा.
Primary position squint, small exotropia is also not there, and she was relieved of diplopia.
पूजा अभी राइट साइड में देखिए, राइट साइड में देखो, अब धीरे से लेफ्ट साइड.
So another case is she was a 18-year-old female with a history of road traffic accident 4 months back. She had lead edema, redness, painful movements at that time. Except for minor small squint, rest symptoms were relieved with the medical management, but the symptoms aggravated after 7-8 days and then gradually increased till for 2-3 months. There was no relief with antibiotic and anti-inflammatory drugs. So right eye was normal, left eye had edema, conjunctival congestion, all restricted movements, and the eyeball was pushed supero-nasally, and FDT was not possible because everything was painful. But on uncovering the lid, she noticed vertical diplopia. So CT scan was advised, and she showed there was a fracture of the medial lateral wall of the orbit with displaced fragments, and there was presence of thick inflammatory tissue and well-defined thick-walled collection. Here you can see the thick-walled collection antero-inferiorly here, and the whole globe was displaced superior nasally, compressing all the extraocular movements. So the diagnosis was query hematoma or query abscess, and there was associated depression of the floor of the orbit without any clear entrapment of the oblique herniation. And in this case, again, because there was large swelling on the maxillary area, also extending to maxillary area, opinion of ENT surgeon was taken, and under his guidance, the exploration and drainage of the organized hematoma, it was an organized hematoma, under GA it was done, and there was full recovery of eye movements after relieving the pressure on the lateral and inferior rectus, causing restriction, and there was no diplopia. So she was pre-operative like this, and the third post-op day she was totally free of symptoms and improvement in the ocular movements. This was a third case, 20-year-old male presented with blunt trauma with a scleral tear at 6 o'clock position 3 months back, sutured that time elsewhere, and then he came with abnormal head posture and diplopia since then. As there was no relief in 3 months, he was referred. On examination, he had a face turn to left, chin depression, and on undoing the head posture, he showed lower lid ptosis, and the FDT there was small exotropia with left hypertropia, and FDT was positive for inferior rectus. There was crossed vertical diplopia, and there was small scar on the sclera at 6 o'clock position, and it showed left inferior rectus weakness. On MRI, there was there were no signs of fracture or muscle entrapment, but there were abnormal inferior rectus signals noted. Adjacent to the floor showed some inflammatory reactions. So there it suggested query inferior rectus sheath adhesions to the floor of the orbit. So this is the scan showing the adhesions of inferior rectus ruptured, maybe ruptured inferior rectus sheath adhering to the floor of the orbit. So because video was long, I just took the photographs. This was after exposing the 6 o'clock area. There were a lot of congestion, scarring on opening the conjunctival flap. You can see so much adhesions and there was a lot of bleeding. And then these few fibers of the inferior rectus were identified, which were hooked. Then I took the sutures and separated. And then this area was exposed, and I tried to look for the inferior rectus fibers. At the infero temporal quadrant, I could see some fibers of inferior rectus. They were meticulously separated, and then by meticulous dissection I could find whole of the inferior rectus muscle there, and then I sutured it along with the residual fibers to the original insertion, and the patient showed relief of the diplopia and abnormal head posture. So preoperatively, first op day, patient was comfortable and then he was perfectly all right. So just few words, last two slides. Post RD surgery, the strabismus is noted in 50% of cases, but it resolves spontaneously and persists only in 3 to 5% of cases, and the multiple mechanisms are noted. It is because of mechanical related to scleral buccal or adhesions between muscle and sclera. There may be fat prolapse, globe distortion, or they may be effect on the muscle pulley. Or so this was a typical case, young adult with scleral buccal in the superonasal quadrant affecting under medial rectus, superior rectus and lateral rectus muscle in the left eye, showing exotropia and hypotropia. FDT was positive for adduction and elevation, and I have not operated yet, but the treatment plan is adequate exposure of the conjunctiva, removal of the buccal, but it is not easy. There must be lot of adhesions, and separating the muscle must be difficulty. But one precaution one must take, that at the end of the surgery FDT should be negative. So to avoid this post-RD surgery strabismus, the meticulous and proper handling of muscle by retinal surgeon is important, and if retinal surgeon should do FDT at the end of the surgery to prevent the further adhesions. So to conclude, clinical spectrum of restrictive strabismus, post-globe trauma and post-RD surgery is very broad. Proper history, clinical examination and ocular motility assessment gives a lot of clues. FDT, timely CT and MRI aid in correct diagnosis, and it's a great challenge for strabismus surgeon to correct the HP and diplopia in such cases, as the results in such cases are unpredictable even after doing meticulous and fine surgery. Thank you.
Thank you, Varsha, for a wonderful talk and very nice set of cases depicting the restrictive strabismus. I just want to ask one thing, that after post-RD surgery, do you excise the buccal while doing a squint surgery, or what do you do to the buccal?
Most of the time we have to remove the buccal to relieve the adhesions and separate, and we have to keep the patient on regular follow-up with the retinal surgeon. And few studies show that in most of the cases retina is usually stable and doesn't affect the retinal status after removing, but mostly removal of buccal is needed.
Okay. So because we do these surgeries many years after the RD surgery, and so I think probably removing the buccal and keeping them under observation is a safe approach, because sometimes with the buccal it is difficult to free the muscle or operate the muscle. Suma?
I do not remove the buccal, because I prefer it to ask the retina surgeon and then remove the buccal. Otherwise, tomorrow
definitely.
So I do a hang bag. I think the hang bag is better, so that you can you don't need to take a scleral bite. So you can do a hang bag like so not a semi hang bag or a pure hang bag incision.
Yes, already retina is thin.
So you have the insertion. So you just take a bite at the insertion, and then like an adjustable only you put the muscle behind on a hang bag. So that helps. You don't have to remove the buccal.
Yes.
We have still 5 minutes left. Any questions on the talks anyone wants to ask? Yes.
Not exactly restrict. So, have you come across any restrictive or any strabismus after AGV, glaucoma valve implants? Because I had recently two people operated with RD valves, and within a month of surgery, they had poor vision, of course, and they had initially exotropias only. But post the AGV, they started having vertical diplopia, large vertical diplopia, and the patient actually started complaining of double vision despite the poor vision. So that's when I evaluated, and I was thinking it's probably a Brown syndrome, kind of restrictive strabismus. But to my surprise, I found that it was mimicking a superior, it was just like a superior oblique palsy. So have you come across, and what would be your strategies? Like the idea is to save the valve as much as possible because it's working very well. So I'm contemplating whether I should think of it like a paralytic strabismus and do an inferior oblique recession rather than going ahead and because then the valve is working well and patient is relieved of his the multiple medications that he's on.
See, now we rarely see buckles. In fact, now what we are seeing is the Adi valve. After that we are seeing the means more like a restrictive strabismus. Also, I have seen 2 cases where the eye is not being elevated. So you can go ahead and do an inferior oblique. I mean, I have given prisms till now because I didn't want to disturb the conjunctiva. So I have given prisms, but you can think of the muscle which you feel is the antagonist, or we can
Have you
release.
come across any paralytic? Like it's mimicking just like in 2 cases.
No, I've not come across paralytic. It is basically I've got a restrictive where the eye is in hypo. Yeah, in both the cases the eye is in hypo. I've kept them on prisms. One, I think I have done an inferior rectus. So, so now that is the next challenge of the valves. The buckles have stopped.
Yes. But another thing that you're doing a hang back, but then I found that most of the times for the buckle, you can't even hook the muscle because there's so
very
much
tough.
of addition. And there's like a pseudo tendon hole over, and so you have to go do a 360-degree peritomy. And
So unless you remove the buckle, sometimes freeing of the muscle is not possible.
Yes.
Yeah, I don't know. Maybe I have few cases which I've done. Maybe the retinal surgeons were so good. I have been able to free. I don't know. Maybe because they have really kept the sheath of the muscle intact.
So like what I found is that if it's a vertical strabismus with restrictive, definitely you feel it there is a restriction. The restriction may be very minimal, but definitely that if you think it's restrictive, it's better to remove the buckle. But suppose sometimes you have these decompensated phoreas going into tropias with exotropias where there's not much of restriction. Yes, I think then in those cases you can save the buckle and you can do any technique hang back or it works well. But if there is a definite restriction, good meticulous dissection and removing the additions helps. And only recessing the muscle helps, no? You hardly have to do any.
You can't resect.
Any antagonistic strengthening because usually
Yes.
the recession alone helps.
Actually, what you're saying is right because see, the buckle thing was there long back. I think also I have not come across in the last 7 years any.
These were older cases.
These are older cases. Yeah,
Yes.
what you can remove the buckle because older cases, yes. Now we'd hardly see anyone because most of them are vitrectomy.
I just want to ask Suma one question is how do you do an LR recession of 18 or 19 millimeters? Because even sometimes doing an 8-9 millimeter recession is a challenge.
Yeah. So what I do is that it's a hemi or a semi. It's a semi hang back, no? So basically I would take a bite at 9 millimeter in between. That
Yes.
I'll take a bite at 9 millimeter.
Hemi hang back.
Hemi hang back. And then I will push the 9 millimeter behind.
Okay.
But yes, 18 millimeter I will measure it, but where the muscle goes and sticks, I don't know.
Because
But I have not yet found that the effect has come. But so maybe it has gone and stuck at 12 or 13, I don't know.
Yes.
But definitely I do a hemi hang bite. Otherwise, it's not possible to do a normal scleral bite. Even 12 and 13 is difficult because there you have the inferior oblique.
Yes.
So always, most of the time then your bite goes to the inferior oblique, so you don't want that. So 9, you take it at 9 or 10, where 10 millimeter is where your inferior oblique comes.
Yes.
So just slightly above it or slightly behind it, you can take the bite.
Okay.
And then you take again in the insertion because you're not taking a proper bite, so like a hemi hang back.
Yes. Okay. So that was one thing I wanted to get it cleared. Any other questions anyone is having?
periosteal. I've not actually done a periosteal fixation for the scare that won't the patients be losing their field. So with the concern, because most of our patients have good vision in DRS. So when you're doing that, what's your the take on that?
I have not done periosteal
But then
fixation
I
for
think,
a DRS.
yeah, I think it is advised, and people have got good results. It can be then combined with SRT for improving the abduction slightly. No? What do you think?
I don't know. I have not been convinced that lateral periosteal fixation is
that's
good
what
for
I'm also not
DRS.
very convinced.
For a the synergistic divergence also, there's one eye which I have done because Dr. Pradeep Sharma said so. I have done in one case. It has worked well, but not for. I would prefer to keep it only for third nerve palsy.
I've done it only in one case of very severe abnormal innervation of LR muscle. So the first I did a recession of that muscle, but still the upshoot and lid retraction did not go, and so then I had to again go back and do a periosteal fixation of.
A
and
large recession works in those cases, like you do 18, 19, or maybe what you're saying is right. You could create into a sixth nerve palsy. You can do like 18, 19, and then you do an
then
SRT.
do an SRT for
That's what
improving
you
the
can do if there is
abduction.
a field effect.
Yes. So with this, we conclude this our IC on unleashing the leash, and I thank all my co-instructors, Dr. Vivek Varkar, Dr. Rishikesh Mai, Dr. Suma Ganesh, and Dr. Varsha Pandey for being a part of this wonderful IC, and I thank the audience for being here. On this last day of the conference. And with this, I declare the IC to be concluded.